Thank you everyone for coming out this evening to participate, hopefully to learn, meet some other patients. Thank you to the Melanoma Network for being here, because I have to say I see the effects of the Melanoma Network in clinic every day, from the patients who have reached out and been supported, from the patient education booklets that we have. It really is a wonderful organization that I'm very proud to be a part of on the board. Okay. So a little bit about what we'll go through. We'll go through this evening. Talk about the incidence of melanoma, who gets melanoma, what some of the risk factors are. Really going to focus on some new and exciting developments in treatment, looking at advanced disease, so patients who have stage 4 melanoma, as well as some really new and exciting treatments that we're using in the setting of what we call adjuvant, or after patients have had surgery to try and prevent recurrence of their melanoma. I can't give a talk on melanoma without a small nod to prevention. So melanoma is one of the most rapidly increasing cancers. An incidence of 1 in 57 men and 1 in 74 women will have a melanoma in their lifetime. In young adults, so ages 15 to 34, it's fourth only to thyroid cancer, and it's estimated there was 7,200 new cases in Canada last year. Fortunately, most of these are caught early, and the 5-year survival is quite high at 89%. But unfortunately, for the ones that are caught later, that number is much lower. So in the blue is the incidence in men, and in the green is incidence in women. And at the bottom, again, not only is the incidence higher in males, but unfortunately the mortality, or the death, is greater in males. When you look at the year-over-year increase, we can see up in the corner here that from statistics taken comparing the sort of 1980s to 2000 period to the more recent time, there's been a clear increase in the incidence in melanoma. And worldwide, there's about an overall 3% increase year over year. It's just a pictorial showing that this indeed is a cancer that affects not only, as with all cancers, there's more cancer as people get older, but this is a particularly significant cancer in the young. And you can see it's there, number 4 in the 15 to 29-year-olds, as well as in the 30 to 49-year-olds here. In terms of risk factors, certainly looking at things like family history, having 2 family members who've been affected by melanoma, having a lot of moles, having a number of those moles that are unusual or atypical moles, being on immune suppression, so patients who've had transplants such as liver or kidney transplants, and certainly a past prior history of melanoma are all unfortunately risk factors for the development of melanoma. And just a little look to what we're watching for here. The dermatologist will talk about something called the ugly duckling sign. This patient has a fair number of moles, but if you look, you can see up in the middle at the top, a little bit below the bone there, we're certainly seeing a mole that looks a bit abnormal. Other risk factors, UV light, the number 1 risk factor, and it doesn't matter if that UV light comes from the sun. Probably even worse if it comes from a tanning bed. That's like UV light concentrated in a box. Certain physical features, light hair, light colored skin, blue eyes, freckles, being male, older age, and a defective DNA repair disease known as xeroderma pigmentosum. Just a few things to remember when you're thinking about where do you get the sun's rays. Well, certainly you get them from overhead, but you can also get it from below, reflected back up at you when you have light or white surfaces, the water, sand, white concrete, and certainly snow as we're coming into, or I think are actually perhaps in winter now, unfortunately. Again, another example of a melanoma, and I'll go over a little bit of how to keep an eye on your moles and try and see. But some of the outstanding features of this one are the little bubbly aspects to it, the fact that it's not nice and round, that borders are ragged and jagged, and it looks like there's been a bite taken out of the middle of it. So nothing really looks good about this mole. So I'm not going to talk too much about surgery this evening because fortunately we have Dr. Francis Goody with us, but just a couple of comments on surgery. It is the primary main treatment when someone presents with an abnormal mole. And we know that there are, for those of you that have had melanomas taken out, rather large, what feels like a large piece of skin, and the amount of surface that's taken out is really dependent on how deep the mole is. So that's when we first get it diagnosed by a biopsy, that guides how large what's called the surgical margin is. And as you can see, that goes from a melanoma that isn't invasive to 0.5 centimeter up to the deeper melanomas over 2 millimeters, where that margin, and literally the surgeons draw a circle around an ellipse around the mole, and that's 2 centimeters. So they go all the way down to the fascia. So these are large excisions. And that's just an example of one. In addition, if the biopsy suggested that your melanoma was over 1 millimeter, or if it was a bit less than 1 millimeter and had some high-risk features, patients would be offered a sentinel node procedure to see if the melanoma had spread to lymph nodes. What's new, and what Dr. Francis Goody will speak more about, is it's been only been in the past year or so that after a sentinel node procedure and the finding of a positive sentinel node, in the vast majority of patients, they don't need to go on to further surgery. And that's really a quite exciting and positive finding for patients. Again, abnormal mole, very dark, very ragged and jagged around the borders. What are the high-risk melanomas? Well, certainly if they're deep, and that's deep in millimeters. And when we measure the depth of a melanoma, it's from the skin deep. Sometimes I have patients who come and they tell me they had these big mushrooms blooming on their skin, and when they were cut out, they maybe invaded a few millimeters when it sounded like there was a good centimeter or two on the skin above. So that's called the Breslow thickness. Ulceration, it's a feature that the pathologists tell us about, and it's a marker of a higher risk melanoma. It doesn't necessarily mean that the melanoma on the surface of the skin was bleeding, but it's a pathological feature under the microscope. And whether or not the melanoma has gone to the lymph nodes is also a higher risk for the melanoma coming back, unfortunately. So adjuvant treatment are the type of treatments that are offered to patients who have had a complete resection or surgery for their melanoma. And these are drugs that are hopefully to help reduce the risk of the melanoma coming back. I'm going to talk to you about those after I talk about some of the drugs that we're using in stage 4 melanoma, because we're going to see how some drugs that work really, really well for patients with stage 4 melanoma are now being brought into the preventative setting. So what's new in stage 4 or metastatic melanoma? Unfortunately, melanoma is pretty sneaky, and it can go almost anywhere. Common places it go to are the liver, the lungs, the lymph nodes, the brain, to other places on the skin. It can really go anywhere though, bone, your bowel. It can be quite difficult for patients. We've known as physicians who've treated patients with melanoma for a long time that prior to the current treatments I'm going to tell you about, we didn't really have a lot of great treatments to help our patients with melanoma. Melanoma is not a particularly chemotherapy-sensitive cancer, unlike perhaps lung cancer and breast cancer. And so there was a large study that had over 2,000 patients from a whole reviewed, the study was a review looking at a whole bunch of patients that had been on all sorts of trials for melanoma, and looked on average of how well they did and how long they live. And from this we know that only about a quarter of patients survive 1 year after their diagnosis. And when you take that out to 2 years, only about 10% of patients are alive and well after a diagnosis of stage 4 melanoma. You're going to see that we've got some treatments that have really improved those numbers. And when you talk about on average how long did a patient live, it was only about 6 months. So these are really, really dismal results. This is probably the first time I've been doing this talk. I looked back since 2011, and this is the first time I'm not going to talk about chemotherapy at all. We really haven't used chemotherapy in the clinic for quite some time, and there may be very limited indications and uses that they would return to it, perhaps waiting for another drug. but it's not commonly used anymore. So I'm going to bypass it. So biologic or targeted therapy. I'm going to speak specifically about a class of drugs called the BRAF inhibitors. So I'm not going to make this not too scientific, but there's growth pathways in our cells, and this one is called the MAPK pathway. It is an on-off switch. It tells cells to grow and survive and to invade, to move to other areas. There's multiple steps in it, but we found drugs that can block a couple of the steps, as I'll show you in the next slide. And we know that roughly 40 to 50% of patients have this BRAF mutation. So if you have a mutated form of this protein, it's like it's stuck in the on switch. And so the growth signal perpetuates, and the cell can't do what it would usually do and turn on and off in terms of growing when it's supposed to and not growing when it's not supposed to. So this is called an activating mutation. So looking at the top, some signals happen outside of a cell, and then they get transmitted into the cell to send these growth signals ultimately that cause the cells we talk to grow or stop growing. So when you have this abnormal form of the BRAF protein, it's like the switch is stuck on. It then moves down to the next protein called MEK to keep perpetuating the signal. That moves down to ERK, and then it moves into the nucleus, and we have this pathway of growth. We have drugs now that block this abnormal form of the BRAF protein. It fit into a little pocket, and it make it start behaving. And so we found, and I'm not going to go into the background studies, that when you combine a drug that blocks this abnormal BRAF protein with a drug that blocks the protein at the next step called MEK, that the drugs work even better. And so the combinations we have right now are vemurafenib with cobimetinib that block the two steps, and also dabrafenib plus trametinib, again, that block these two steps, and we stop that growth signal. And what happens when we stop the growth signal? The tumors stop growing and they start to shrink. So the first big study of the combined drugs was published in 2014, and I'm going to show you some updated results that were recently just presented at the European Society of Medical Oncology last month. Just to give you a pictorial example of what we see from what goes on in the inside, here we're looking, so this is like body slices, they call it the bird's eye view. You're looking up at the lungs. So the lungs should just be basically black, and all these white spots that you're seeing are abnormal. This is the liver, and again, all of these dark areas are abnormal. Abnormal meaning those are tumors. And then over here, they're showing us that in the bone, in the rib, there's a tumor as well. And this is a picture of patients being on treatment for just 8 weeks. The CAT scan repeated. We can see the majority of these abnormal spots have gone away. The tumors in the liver have shrunk considerably, and the tumor over here in the bone has also pretty much gone away. So the updated results presented and published are showing that when we look out at patients who've been 5 years after beginning treatment with these drugs, we're seeing that there are a lot of patients still alive and well. And so when we look, the blue line is just using the single drug, dabrafenib, on its own. That's the light blue line, rather. The dark blue and the yellow lines are when the drugs were combined. We're seeing that around 30% of patients are alive and well without further growth of their tumor when they're out at 5 years. And so remember, we talked before about only 10% of patients being alive and well at 2 years. So the impact that this has had on patients with melanoma really is remarkable. So some of the numbers depended a bit on whether they were getting different dose, but roughly, again, about 30% of patients. In certain patients, so patients who did not have a lot of tumor, the melanoma had only spread to a couple of different areas, for example, maybe the lung and the lymph nodes, and a blood test called the LDH was normal, we're seeing about half of patients are alive at 5 years. So things are starting to look a bit brighter. I think I see something starting to grow. Now we're going to look at immunotherapy, and immunotherapy is really a new pillar of cancer treatment. Traditionally, we've had surgery, we've had radiation, we've had chemotherapy. The targeted therapies of new, they've been hormones and things along those lines for many years now, but immunotherapy is really something that's been quite revolutionary in the treatment of patients with melanoma. This doesn't project quite as well as I like, but I do like the picture. So this is your tumor cell, and this is your body's immune system trying to fight the tumor. The tumor just does this. I can wipe you out. You can't wipe me out. However, this is your body on immunotherapy, and we really have something that can hammer down those tumors. Again, a little bit of biology. We'll go through a couple of pictures. So we have something called an antigen-presenting cell, or a cell that is presenting a little piece of melanoma to your immune system. That cell in your immune system is called the T cell. However, the antigen being introduced to the T cell isn't enough to get the immune system revved up, excited, multiply, call in the troops to go attack the tumor. It's something called co-stimulatory molecules. So there's another interaction that happens, and then we start getting that immune response. And remember, this response is usually out there because your immune system's out there looking for bacteria and viruses, and it attacks them, and it revs up. But of course, you don't want, in the setting of treating an infection, your immune system to be constantly revved up. So it's quite smart. Really, from the time that it starts to activate, another interaction takes place between the same receptor on the antigen-presenting cell with a different receptor on the T cell, and that says stop. It's time to wind back down. We've done our job. So this was really exploited as a way to, well, what if we can take our foot off the brake, stop the stop signal. And something else was supposed to come up there. We have a drug that does that. It's called a CTLA-4 inhibitor. It's better known as ipilimumab, or to patients probably to be known as Yervoy. And it was the first immunotherapy drug that was approved to treat patients with stage 4 melanoma. So results look very exciting originally, but what was really exciting is when they started to publish long-term follow-up of patients who'd been treated on ipilimumab. And some of the data we have from this isn't even from the original clinical trials, but it's actually when the pharmaceutical companies went to large cancer centers and said, we're going to give you compassionate release of the drug, but we want you to still report on side effects. We want you to still report on how well the patients are doing. And they followed the patients for years. And the results of this are pretty amazing. So what we have here is what we call a flattening of the curve. And it looks like if you survived for about 2 years, this is after 4 doses of ipilimumab, you went on to survive. And that 3-year overall survival rate is about 20%, and it's persisted. And we know that there's patients who are alive and well 10 plus years after being treated with 4 doses of ipilimumab. So again, this is completely mind-blowing and life-altering for patients who have melanoma. But we knew that blocking that one receptor is a bit of a simplistic story, and there's actually many checks and balances in the immune system, and there's steps that rev up the immune system, and there's steps that turn off the immune system. So those have been a very active area of study or investigation. And another class of drugs called the PD-1 inhibitors, and you'll know these drugs as Opdivo, we call it nivolumab, and Keytruda, pembrolizumab, are both of this class of drugs called PD-1 inhibitors. So I'm going to go to a little cartoon again. It's a little bit busy. We'll deal with one side of the page first. So what I was just talking about was how ipilimumab works, and it blocks the CTLA-4 receptor, so we stop the off signal, and those T cells can multiply and stay active and go and attack tumor. This is occurring in a lymph node, right? The T cells are getting activated in the lymph node. Then they have to truck through the system and actually make it all the way to the tumor. So one thing we knew with ipilimumab is that it was not a very fast-acting drug, and patients often had to be on it for many months before they started having good response and tumor shrinkage. But unfortunately, we also know that sometimes melanoma can grow pretty quickly, and patients don't have months to wait for their tumors to start shrinking. So the difference here, we've got our activated T cell. This T cell has already met the dendritic cell. It is primed. It's ready to go. It's going to recognize a piece of melanoma. So this is a T cell recognizing melanoma as something that's alien, that doesn't belong, just like the virus doesn't belong, okay? So it meets the tumor cell. The tumor cell tries to still foil the T cell by expressing something called PD-1. And when the PD-1 ligand interacts with this PD-1 receptor on the T cell gets shut down and it can't attack the tumor. So that's where these other drugs come in, the nivolumab and the pembrolizumab. They block their PD-1 inhibitors, their PD-1 receptor inhibitors. So they block this receptor on the T cell, so it is blind to the PD-1 ligand on the T cell. It can't see it, so the tumor can't try and block the T cell, and the T cell can be active and go ahead and kill the tumor. So one of the key studies, there's lots of background to these, but one of the key studies was done is this newer generation or class of immunotherapies better than the original one, the ipilimumab or Yervoy that I just told you about. So this was a study called the Keynote 06. We actually had this study open at the Juravinski and put several patients on it. And again, this has just had recently published updated results at ESMO this year in October. Now we're looking at patients who are out, an overall survival here for about 45 months. We're really looking at about 4 years, and we're seeing that 40% of patients, just over 40% of patients, are alive and well. Okay, about 4 years after being diagnosed with metastatic melanoma. Now, this is clearly better than the ipilimumab. So the pembrolizumab is in the green arm, the ipilimumab is in the kind of brown arm, and we can see these patients are living much longer. The difference between the left side and the right side of the slide is some of these patients could have had prior treatment, and these are patients who were previously treated. And what's pretty amazing here is we can see all patients are responding, whether they've had treatment prior to receiving the pembrolizumab. So again, completely life-altering. Well, if each of these drugs works well on its own, what happens if we combine them? Well, many things. Most importantly is they work better. So I'm just going to walk you through how this trial worked. So these trials are all randomized, and it's a computer-generated randomization, which means I can't pick what arm of the study you're going to have, and you can't pick which arm of the study you're going to have. Your name turns into a number, it goes into a computer, and it says, okay, you're on the 2 drugs, and you're on the 1 drug. We don't know what you're on, and you don't know what you're on. It's completely blinded. So the patients who received 1 drug also get a placebo. So everybody is getting 2 drugs. I'm just going to comment a little bit about dosing because this gets pretty relevant when we start talking about side effects. So here, patients are receiving a dose of ipilimumab of 3 milligrams per kilogram, and the nivolumab is 1 milligram per kilogram. After you receive 4 doses of the 2 drugs together, then you go on to receive just the 1 drug, the nivolumab, on its own every 2 weeks. This projects well. Okay, so looking at response rates. This is in the combined arm of the nivolumab plus the ipilimumab. Lots of patients on this study, 314 patients. Response rate of almost 60%. That compares with nivolumab on its own, about 45%, and the ipilimumab on its own, just under 20%. One of the things of note of this study is it was really powered to compare the combination or this drug versus the ipilimumab alone. It's a subtlety, but the study wasn't designed to compare this versus this in terms of its statistical analysis. And here's something pretty amazing to see in terms of looking at the survival curves. So as you can see here, about 53% of patients who received the combination versus 46% of patients who received the 1 drug, which is the blue line, the nivolumab, are alive and well at 4 years. So over half of patients now living out past 4 years, which is really pretty remarkable for our patients. One thing that's really important, because this happens not infrequently and invariably is worrisome to patients, is in those 4 doses when the 2 drugs are combined, if patients have a significant side effect, and many do, we actually stopped treatment. And the way this trial was designed, if you had a serious side effect, and we're going to talk about those, you didn't go on to receive the nivolumab or your placebo at all. You actually had to stop. Those rules have been changed a little bit, but they've analyzed all these results, and patients who had anywhere from 1 to 3 doses of ipilimumab plus nivolumab with no further treatment, they did just as well. And so it really speaks to how much drug do we need to give people? How long do we need to treat patients? These are questions that we don't have to have the answer to. But what we can reassure from patients from information like this is, if we have to stop treatment because of side effects, from what we can tell, they do as well. Okay? So side effects. The side effects are autoimmune in nature. So again, these are drugs that are boosting your immune system. So the side effects are those of an overactive immune system. What are the most common things? Well, rash. And the rash can be itchy or not. It can be really quite annoying, but typically something we can easily manage. So skin rash. The other most common side effects we can see are it impacts our endocrine glands. So we have a thyroid gland, we've got a master gland called the pituitary, we've got little adrenal glands that sit above our kidneys. They can all stop functioning. They basically get burned out from an attack of your body's own cells, but these glands all produce things that are really easy to replace. A pill a day to replace your thyroid. Unfortunately, there are some rare side effects that can be quite troubling. And also inflammation of the bowel. So diarrhea, bloody diarrhea, one of the more common side effects. Inflammation of the liver, or what we call hepatitis, a drug-induced hepatitis. The more less common side effects, inflammation of the muscle, so muscle pain, inflammation of the joints or arthritis, and that can be quite troublesome for patients. We can also get inflammation of the nerves, inflammation in the brain, inflammation in the eyes, and the heart. And those are all quite rare, but can be quite serious. We know with inflammation in the heart, which is very rare, less than 1% of patients, up to half of patients may die from that. We can also cause diabetes. But again, we can give insulin for life, but there are some side effects that unfortunately can be long-term. Most of these side effects, though, with the heart aside, again, very rare, are well managed with the use of steroids. And so the other big difference we see when we combine 2 drugs versus 1 is that the side effect rate of serious side effects is about 60% when we combine the 2 drugs, compared to just the nivolumab alone, about 22%, and ipilimumab alone, 27%. And, it's one of the features that help us when we are having a conversation with patients about using 2 drugs versus 1 is you absolutely have to take the side effect profile into account. Even though we know that the 2 drugs work better, there is some cost in terms of side effects. A little bit of potential optimism, again, this is just fairly recently presented, is they reversed the dosing and gave 3 of nivolumab with 1 of ipilimumab in those first 4 what we call induction doses. And it looks like, this is very early days, really just kind of out around a year, it looks like these 2 curves are the same, meaning possibly doing this lower dosing strategy is good enough in terms of response. But as you'll see, it is much better in terms of side effect rate. So when we switch to the 3 with 1 rather than the 1 and 3, about 34% of significant side effects. This is now down to 48% from 60. We think that possibly that's because all of the investigators have a lot more experience in managing the side effects that we see with the combination. Some things that are different is if you're just using nivolumab or pembrolizumab on its own, it would be very rare to get multiple side effects. So to get, for example, inflammation of the lungs plus inflammation of the liver at the same time. With these drugs, you can get multiple things happen at the same time, or you treat one side effect, for example, the diarrhea, and as we wean patients off their steroids, a second side effect pops up. And again, that's pretty uncommon when we use just one drug. So that's certainly good that it looks like maybe the severe side effect rate is a bit better now that we have a few years of experience using the combination, but it certainly is still higher than the reverse dosing. So to summarize here, we know that with ipilimumab alone, 20% of patients are surviving at least 5 years, probably 10 years and onward. Can we say cure? Possibly, right? That's a pretty exciting concept when we're talking about stage 4 melanoma, but these are patients who are doing well for a long time. When we look at the PD-1 inhibitors, again, about 40%, 4-year survival, and the combination just over 50%. And again, those dismal numbers from before are really in the distant past now. So again, things are starting to blossom a bit more. So adjuvant therapy, and again, this is the type of treatment that we give in the post-operative setting for patients who've had their melanoma completely resected or cut out. And when the melanoma is either very deep or it's spread to, more typically when it's spread to lymph nodes, we know that it's had the ability to escape, and we're worried that maybe there's some microscopic cells still out there. And so we're giving these drugs to try and kill those microscopic cells so the melanoma doesn't recur in the years down the road. And so some of you in the room may have gone through interferon. It had been the only drug we had for decades. The first study of interferon was in the late 80s. And they really continued through till maybe about 8 years ago. There's lots of meta-analyses or big studies of trying to see really how well do these drugs work, because we know they're quite toxic in terms of side effects. And maybe at best, we improved the cure rate by 2 to 3%. So it was a pretty difficult risk-benefit ratio when we were talking to patients about these drugs. And it was a 12-month treatment program. Lots of patients dropped out. Lots of patients had a dose reduction, and at least a quarter of the patients said, "Why are you even telling me about this? I would never take that drug for a minimal benefit." But it was all that we had. Side effects, I'm not going to go through this in detail, but they were pretty significant. So again, I mentioned when we found really good drugs that worked for stage 4 melanoma, very quickly they moved into this setting of offering the drugs to patients after they'd had their surgery. And so the first study was done with ipilimumab in stage 3 melanoma, so patients who had melanoma that had spread to their lymph nodes. A big study, almost 1,000 patients, 3 years of treatment. So it's pared down since then. That was a pretty long study. They got those first 4 doses over 12 weeks, and then they got what was felt to be a maintenance dose once every 3 months. And we saw very clearly, this is the ipilimumab treated patients in the blue line and the placebo-treated patients in the red line, very significant improvement in survival. So at 5 years, just over 65% of patients who received ipilimumab and about 55%. So absolute 10% difference in the cure rate. So, that logical step, we know that nivolumab, or the PD-1 inhibitors in general, are much better tolerated than ipilimumab, and they're more effective. So they were compared in this setting. So again, big study, just over 900 patients. They received the nivolumab every 2 weeks for a year, or ipilimumab in the same way that we've given it in the prior studies. And again, this was for stage 3 melanoma, but also patients who had stage 4 melanoma. Maybe they had a single metastasis or tumor that had spread to the lung that was cut out, and there was no evidence of disease. They were also allowed entry on the trial. And so here we have in the blue line nivolumab, and in the green line ipilimumab. And this is not, I presented earlier, overall survival. The data for this study is a bit earlier, so it's something that we call recurrence-free survival. But patients who are out at a couple of years without having any recurrence of their melanoma, again, an absolute 10% improvement, 71% versus 61% of patients with the PD-1 inhibitor. And similarly with pembrolizumab has also been studied compared to a placebo, and we're seeing 75% of patients versus 61% of patients with no recurrence of their disease. The dabrafenib and trametinib, the oral targeted therapy that we talked about, has also been looked at in the postoperative setting. Pretty big study, again, about 900 patients for a focus on patients who had node-positive disease, but not patients who'd had stage 4 disease with surgery. And again, an absolute improvement in survival in the range of about 10%, favoring patients who had the targeted therapy compared to 2 placebos. And we also had this study open at the Juravinski. We put more patients on the study than any other site in Canada, actually. So a thank you to our patients. So I think things, if we can prevent melanoma from recurring and ever getting to stage 4, then we're really starting to see some pretty positive here. A little word to risk reduction strategies. No tanning beds, no question, no discussion, no debate. I need to let you know that the Melanoma Network was instrumental in helping pass that tanning bed legislation. Oakville was the first city in Ontario that had tanning beds banned to under 18. There's variation across country in the banning of tanning beds under 18, but some surveys and polls have shown that a really concerning age group in that grade 7 to 12, their use of tanning beds doubled from the late 90s, early 2000s to a few years ago. So this is really a group we need to get at, because we know a lot of risk for melanoma is burns and tanning and sun exposure at a younger age. So surveillance, what do we talk to our patients about? What do we want you to watch? We call it the ABCs. So asymmetry, if you were to cut the mole in half, one half would look different from the other. Border, the ragged and jagged. Color, so it's either getting black or it's getting new colors, or it looks like it's losing color, something bigger than 6 millimeters. And evolution or change over time, which is really key. So a mole that used to be flat that's raised, or certainly a mole that bleeds, needs prompt medical attention. That's abnormal. Prevention, sunscreen. Reapply every 2 to 3 hours. Should be a broad spectrum, so UVA, UVB, in the range of 30 to 50. Wide brim hats, not ball caps. SPF containing clothing. And our summers are short. I know we like to get outside, but if there's things that you really like to do, if you can avoid peak sun hours, so do cut your lawn, go in your garden earlier in the morning, later in the day, play golf early in the morning, later in the day. But if you're going to be out, we'll be sun safe, we'll be sun smart, wear the sunscreen, reapply, and I think we're really heading to a bright future if we can also get a bit more prevention. Take-home messages. Our therapies are having really a significant impact on the lives of patients with melanoma. Patients are now living for years instead of months. It looks like we may be doing a much better job at preventing the melanoma recurring. But overall, we'd like to see a decreased rate of incidence. And if you are going to be on the beach, I hope you look something like this. Thank you. I'll take any questions. So for the purposes of these, it's from the time you started on the trial, right? So from the time you signed consent and went on the trial, it's timed from that. I mean, it's an excellent question. It goes probably all the way back to medical school. There's very limited dermatology in medical school. Most medical schools still today have what I had, a decade ago, day in dermatology. And so certainly some family physicians who have a particular interest do extra dermatology. It's certainly an area of outreach and education. The ABCs, a bleeding mole, these are things that you can't ignore. A blood blister. Yes, you get blood blisters when you jam your thumb in your car door. If you have a blood blister pop up on the middle of your back in the absence of trauma, that's not a blood blister. So I think there's certainly room for going right back to medical school in terms of our training to help there. We need more dermatologists probably. Again, that's provincial, federal issues. They only train so many of them. But because not all family doctors are going to be comfortable checking skin lesions, they would like if they had easier access to refer patients to a dermatologist to get them all looked at. The dermatologists don't just look by eye. They have these little devices called dermatoscopes, and that can actually look under the surface of the lesion, and they're trained in looking at the pattern of blood vessels and some other details that tell them, oh, this mole looks normal or this mole doesn't. So it is multifactorial. Part of what we try and help with in the Melanoma Network is, though, of course, if you've met the Melanoma Network, you've already been touched by melanoma, is advocating and being a patient advocate for yourself. Certainly a story I hear from some patients is, they weren't happy with the doctor who was saying, we'll keep an eye on it. And just being that squeaky wheel and saying, what, I know this is different. I looked at a picture of me from Christmas, 2015, and this is different. And just pushing to get someone to biopsy it. At a center like ours, it's fairly smooth process. I mean, our surgeons are going to refer all of the high-risk melanomas to see a medical oncologist. And that's one of three now, myself, Dr. Tozer, and Dr. Healy. We're huge supporters of clinical trials. The first thing I think when I meet a new patient who's been sent by a surgeon or a patient of mine who unfortunately has had a scan that's shown their melanoma come back is, what's the right clinical trial for you? I think it's really how we operate here. And if there isn't a trial in that setting, then we look to what standard therapies we have. Yeah, so I mean, these trials in the post-operative setting, all of those patients would have had their surgery within the past 3 months. So there's pretty strict criteria for going on those prevention trials. Yeah. It is. I mean, to train physicians, we can not always, but usually tell a squame from a basal cell from a melanoma by exam. Certainly from the patient's perspective, again, it's a mole that's changing, abnormal. Often something like the basal cells are a little area of redness that just flake over and heal, and if it just looked like that for 2 weeks and went away, it was whatever, was nothing. But if it does that for months on end, it's something that needs to be checked. No, so basal cells and squamous cells don't transform into melanomas, no. They're either de novo, so brand new abnormal moles, or existing, what we call congenital moles that you've had for decades can turn into melanomas.
Thank you.
Okay. All right, thank you.